let's begin. This is your bronchiolitis scoring sheet for the bronchiolitis pathway. We did some revising of it. It is now going to parallel more precisely with the Seattle Children's model than any other previous models we've used before. Basic scoring here is a 0 through 3 process with the criteria listed below here, so you need to read through and familiarize yourself with the criteria and what we need to be looking for when we're assessing the pediatric patient. Over to the left here, we have respiratory rate, retractions, dyspnea, and auscultation. The findings should be recorded here. Also in Power Chart, where we record them, is on respiratory therapies. The very bottom where there's treatment comments. All you have to put in was what your RS score was. A progress note at the end of the shift, especially dealing with children who are in the mid to high range when it comes to the pathway, is advisable to as well to let everyone know what you did with the patient throughout your shift. So keeping that in mind, this looks familiar. Make sure you put a patient sticker on the patient chart as well. I did take out the normal respiratory rates for 2-month-old, 2 to 12-month-old, and 1 to 2-year-old because it's fairly confused folks. So we'll remove that from there. So scoring is basically anything less than 60 is going to get 1 point, and then the various criteria for the various age groups here as well. So we always think that the circle is not driving you crazy and moving it all over the place. Can't help myself. So this is the scoring sheet. Moving on. The overall bronchiolitis pathway, we're going to refer to it as a pathway, not a protocol, because we still are working with physician-driven orders and not just a protocol in which we're able to operate given certain criteria or assessment. So the way this works is we have low, moderate, and high scoring. RS scores 1 through 4, RS scores 5 through 8, and RS scores 9 through 12. So this has not changed. Inclusion criteria has not changed. It's still greater than 1 month and less than 2 years. That is clinically what the American Academy of Pediatrics looks at as a patient having bronchiolitis. Symptoms of bronchiolitis, signs of bronchiolitis, exclusion criteria are listed off to the left here. Weaning oxygen, non-high flow is listed off to the left here, and then the criteria for titration. So we have to have an order for this. High flow nasal cannula, consider high flow of significant hypoxemia. So what is significant? Well, we've listed it here, and this significant hypoxemia is based off of PALS criteria. So while we're on the subject of oxygen, let's talk about how high flow is going to work here moving forward. So the high flow nasal cannula, we now have a minimum and a maximum range, and this is again based off of what Seattle Children's does. We were going to initially start with weight-based. Then as high flow began coming into play here in about 3 or 4 years ago, we looked at a softer min-max. And so now we're just going to go with, again, Seattle Children's. So you have your age criteria here. So if we had somebody who's greater than 6 months and less than a year, let's say a 10-month kid, we could start at a minimum of 5 liters per minute and move to a maximum of 8 liters per minute. Our starting FiO2 should be around 40%. We're allowed to titrate the FiO2 based on SpO2 of 90, greater than 90 for an awake child, and SpO2 greater than 88 for a sleeping child. The score and suction and vitals Q30 minutes is a safety check because as we're moving a patient to high flow nasal cannula, they should be in this moderate to high range. And we want to make sure that we are following the patient closely and that they're not deteriorating. So this is why you have the intense suctioning, scoring, and vitals assessment. After the initiation of high flow, clinically worsening, contact the hospitals. We should be working hand in hand with them. And so if they are clinically worsening, we're going higher and higher in FiO2 and we're at our max, we really need to consider a PSC. Some other criteria here that we need to consider an MG. And then weaning, we may wean Q4 hours by 1 liter increments. For clinical improving, wean on 2 liters times 4 hours. Transition to 1 liter nasal cannula, assess after 10 minutes, and wean off VO2 2 hours after want us to consider is using a albuterol med trial once if it wasn't previously trialed in the emergency room. The rest is relatively normal. Suctioning goes up as the score goes up. So a low scoring child should need more than Q4 suctioning. If you're needing more, maybe you need to reevaluate what your score is. Discharge criteria doesn't mean that the therapist is discharging the patient. The physician will discharge. It's just criteria that we need to look at. And as we provide feedback to the patient, a little bit of a correction. As we provide feedback of the patient to the hospitalist, these are things to consider if conditions are met that we might consider discharge. Physicians asking, what do you think the patient status is and what does it look like to discharge this patient? Because they can and will ask these questions. So this is pretty much intact to what we've worked with before with a few newer nuances, especially dealing with high flow. Consideration of the albuterol med trial, usually times 1 if they're in the high category. And then after initiation of high flow, some checkdowns that we need to look at, from observing feedings by the RN to when to place an NG. I hope this helps. It gives you kind of an idea of why we made the corrections, what we did, who we're basing the data on. This is based again off the Seattle Children's model, well-established pediatric hospital. And this is how we're going to utilize this pathway moving forward. Thanks, and have a great rest of your day.